We're going to be beginning in the first meeting of the study committee. Study committees are not something that I do frequently. However, I have felt that as we have looked at issues, there are certain ones that seem to get pushed aside, or we never look at them in the way that we are going to do with this committee. So that I'll go further into that. But first, let me introduce our committee. We have one person missing today, Representative Rick Jaspers, and I think we probably ought to give him a pass because what time was it yesterday, Lee, that we learned in the afternoon sometime that he was a brand new grandfather of a little baby boy weighing 5 pounds plus. Baby and mother and apparently representative are all doing fine. So if he doesn't make it in today, that's why Representative Jasper. Our committee members are Dr. Representative Betty Price, Representative Bennett, and my vice chair, Dr. Dentist, Representative Hawkins. I, of course, am Representative Cooper. I am a nurse with an advanced degree in nursing. Leo is our committee aide, researcher, great person of all things and information. And, you know, a lot of times we just do this with representatives, but I have been fortunate that we have several people from the community that have agreed to serve and give of their time to this committee. And I am going to call on each one and let them briefly introduce themselves. And I'll start right here to Leo's left. Dr. Walsh, you're on.
Well, thank you. And Madam Chair, it's a pleasure and honor to be here. Thank you. My name's Steve Walsh. I'm an anesthesiologist in Roswell. I've been in practice in Roswell, North Fulton Hospital since 1985. And I am currently the president of the Medical Association of Georgia. Madam Chair asked me to share some personal items if I could, and so I will. And I guess on the personal professional side, one of the things I've enjoyed working on is quality improvement. We absolutely need to put our focus there, but because that's where our success will come from. One of the more recent projects that I've been involved with is the HAPPY program. And the HAPPY program is a program designed to reduce the risk of non-ventilator acquired pneumonia. And one of the most essential elements of that program is having patients brush their teeth while hospitalized 3 times a day with the appropriate toothbrush and toothpaste. And taking those measures, the science shows that you can significantly reduce that incidence. On the very personal side, I am married to Jane, my wife, who is very interested in Georgia native plants. So I kind of see myself as the yard mule. I do a lot of work in the yard, moving plants from here to there and planting them and then digging them up to move them to another location. But what I've seen over the time in helping my wife in that effort with native plants is how the bees and the birds have blossomed in our yard. So,
thank you very much. You know, I took a course one time was part of a course on how to do introductions, and I find that people like to know a little bit personal about you. So that's why I ask. And, usually people get up and rattle off degrees, and that's interesting, but it doesn't give you anything about the person. So next we have Dr. Feisen. Is that correct?
Felsen.
Felsen.
Yes.
Sorry, sir.
My name is Greg Felsen. I'm an infectious disease specialist. I am boarded in internal medicine, infectious diseases, and through the American Academy of HIV Medicine. For the last nearly 4 years, I've been the medical advisor for the HIV unit at the Division of Health Protection at the Georgia Department of Public Health. I've been seeing HIV since about 1992 and hepatitis C since about 1996. when we were at Vanderbilt, and we thought we were doing good things at the time, and we had an 8% cure rate of Hep C, and the national average was 6%. So we thought we were way ahead of the curve, and now all the current therapies are all oral, 8 to 12 weeks for naive patients with 95% cure rate. So hopefully we'll be able to eradicate this disease quickly within the near future. I am also an expert I grew up, and my expertise is in rural healthcare. And one of the things we've been doing for the last several years is expanding telemedicine, which we have 161 health departments in the state, and all of them have telemedicine capability. So we are moving forward with that, and our next step is hopefully move forward with committees such as this and having discussions around Project ECHO. If those of you are familiar with that, it is a way of supporting providers throughout the rural areas of the state, and not just medical, but police departments are using this platform for better communication and being able to get information submitted and distributed in a more rapid rate than we currently are doing. On a personal note, I will follow Dr. Walsh here in that I am a lover and supporter of the state insect, which is the honeybee, if you didn't know.
Okay.
I am a beekeeper.
See?
And thank goodness I'm not allergic, because I get 3 or 4 stings every time I go out there, but that's the way it is, and love my bees. And we'll have our first batch of honey probably in the coming weeks. So very, very excited about that. And if need be, I can bring them over and pollinate for a nominal fee. If you would like me to do that, I'm happy to do that.
I was just going to ask if we got samples. I didn't know we were going to get somebody coming with your bees, Dr. Felstein. Thank you.
And first of the year, I'll just note I'll be taking the UGA has a certification exam, so you can go through the program and be certified as a beekeeper. So hopefully I'll do well with that.
Okay. Okay. Karen Sicard, you're up next. And
Hi, I'm Karen Sicard, registered respiratory therapist. I've been a registered therapist since for the last 39 years, practicing in Connecticut, upstate New York, and I've been here with the WellStar system for the last 29 years. I'm also the past president of the Georgia Society for Respiratory Care. I serve now for the Georgia Society to our national organization as the House of Delegates representative. So I'm love what I do for many years. Have worked on projects for COPD. We are now incorporating HAPPY in our post-operative. So a lot of good things. I am a grandmother of 5.
Wow.
So last were twins, and we're real excited, all healthy and well.
Great. Okay. And Dr. Yolanda Graham.
Thank you, Madam Chair. My name is Yolanda Graham. I am a child and adolescent psychiatrist. I serve as the medical director at Devereux in Kennesaw, which is an inpatient residential facility for children and adolescents, and also as the executive director for mental health services at Devereux, which is in 14 states. I currently am the president-elect of the Georgia Psychiatric Physicians Association and the past president of the Georgia Council on Child and Adolescent Psychiatry. So all things mental health, all things child. My specialty is actually sex trafficking. I've been working with children who have been victims of sex trafficking in Georgia for the past 18 years, and was early on in helping Georgia to try to eradicate this problem, and it continues to be a problem, and especially with us getting the Super Bowl, we have to be especially conscious of that. That unfortunately increases the incidence in every state, so we'll be fighting that in the upcoming 2 years. Something special about me or different, I'm from Albany, so I am Albany, not Albany, although I spend a lot of time in upstate New York. And I love raising kids so much that I have a 27-year-old and a 10-year-old. So it seems like it's a never-ending process. But I encourage anyone, if you're considering it, to do it as much different the second time around when there's a generational gap.
Oh.
Thank you.
Well, okay. I think I didn't give the legislators, Rick, we've already talked about you being a new grandfather, and I had given you a pass for missing on us. Representative Bennett, is there anything personal you want to tell anybody about you? You are a physical therapist, right? Yeah, right.
But in my fun time, I just like to just hang out on the beach. And then when I can't get to the beach, I just watch Young and Restless.
Betty?
Well, I usually say that I like jumping out of airplanes, but it's been a few years since I've done that. So I'm an anesthesiologist. I was at North Fulton Hospital prior to Dr. Walsh, who came after I did. I'm pretty boring, basically. Well, what else? I don't watch The Young and Restless. Don't watch much TV. But anyway, yeah, I've been involved in our city council in Roswell, which gives you a lot of understanding of acronyms. So whenever you see a 3-letter acronym, you usually try to figure it out before you admit to someone that you don't know what it means. And in the city, it's a whole new language, of course, which luckily applied once I got down here to the legislature. My husband is Tom Price, who's the Secretary of HHS, so that gives me a lot of sort of inside scoop as to what's happening at the federal level, so that's very helpful. And I just appreciate being here. Look forward to this committee.
And has a very handsome son who just cut his hair off, but is a rock star in Nashville. Is that right? With a band.
Yeah, he is, actually.
Yeah, it's funniest thing about that.
He's heading to Australia today for a 2-week tour, so he's getting to see the world. It's a very exciting life for him.
That. Okay. Do I get to tell him that you have 7 kids? And how many grandchildren? And 2 brand new ones almost. 3 months old?
Yeah. We're in the midst of raising a second family now. At least my wife looks at it that way. We have 8 grandkids, and she spends quite a bit of time down in Smyrna, where I joined her Saturday and Sunday. Our daughter there has a 2-year-old, almost 2, and a 3-month-old, both boys, and she needs help. So my wife is more than willing to help, and that means that I come too, because my wife says she can't do both of them at the same time, which is fun. I enjoy it, and we obviously love kids, and so we're continuing that journey, and it takes a lot of our time, but it's time well worth it. So. But I'm happy to be here with y'all and here today. Thank you.
And I guess, I don't really have a claim to fame except my corgis. I rescue corgis. My current corgi, Sophie, was the poster child that helped us pass. I don't know whether you know, the state dog is now the rescue dog or the adoptable dog. So we were trying to push people to adopt all sorts of dogs. And Sophie appeared on a flyer that went out on all the legislators' desks saying, I was an adopted dog, please pass this bill. And it passed, I think, almost with no dissenting votes. I'm not sure. There were a few full Bulldog fans that wanted the Georgia Bulldog, but it is our state dog now is the adoptable dog. I did this so the committee could sort of know a little bit more and a little bit more personal about us. As related to, it's been really funny as people have wondered about this. What?
Cat.
I don't think so.
Not yet.
Okay. Oh, I can hear it comes. As I started the committee, because of the title, everybody want the bumblebee to be. Everybody thought this had to do with certificate of need. So if you're here on certificate of need, it has nothing to do with certificate of need. You don't have to come back. You don't have to worry about it. We are going to do nothing on certificate of need. So that was mainly for the lobbyists. But what is about, we have a list of topics that we're going to cover as we go forward. Our next meeting will be on obesity, concussions, and reducing cancer in young people. We are really going to focus on, when we said barriers to health care, these are going to relate to, we may touch into some areas, but they're mainly going to relate to, do we need to change our laws? Are there laws impeding the delivery of health care? that relate specifically to these illnesses? Are there regulations that relate to it? I mean, one of the reasons that we haven't, and nobody wants to hear this if they're on the other side, that we have not expanded Medicaid is because if you want to be a Medicaid providing physician or dentist, there is a federal law that says you now have to have, if you take one Medicaid patient, you have to have all your information translated into 12 different languages. Now, if you're a dentist in Ocilla, Georgia, taking and wanting to take Medicaid patients, but you're just getting by with your dental practice, translating all your materials into 12 different languages is a barrier. And the other part of that is if somebody comes in and wants you to have a translator, the provider has to pay the translator. So, I mean, that's the type of federal law, and I will say that Dr. Price has asked and is looking at this kind of thing to see about the barriers to health. I mean, I'm working on elder abuse and elder deaths now, and we have had several suspicious deaths in the country, and CMS will not give our district attorneys the medical records from the nursing homes. And their response is, that belongs to us. And so that is impeding the investigations, even though there is a state law that says in those cases they are to give it to us, and it is a regulation, and federal regulations do not override state law. Now, federal law overrides state law, but not federal regulations. And yet, CMS will not give it to us. We've had to go through a rigmarole, and we are finally to the new Secretary of Health and Human Services and saying, please settle this. We can't get it settled anywhere else. So those are the kind of things that we are going to focus on in this committee. So first up, and we will be covering things like mental health, telemedicine, obesity, HIV, insurance issues, prior authorization, chronic diseases, and the emerging diseases such as TB, Zika, Ebola, malaria, this kind of thing. So it's sort of a broad spectrum looking at where we stand on those issues. We already know across our state that, we have chronic problem with physicians and not having enough physicians. And of course, the physicians are the top of the healthcare team and the director for the healthcare teams. And we are looking at those in other areas. I see a lot of nurses here, nurse practitioners. You're certainly welcome to come. You are a vital part of the team. I'm glad you want to learn about these illnesses, but this is not about scope of practice or expanding anything to do that. We will not be covering that yet whatsoever. This is about the diseases that we face. So just wanted to make that clear. And we have just had our first presenter. She was presenting in another area. So I would like to call on Dr. Jean O'Connor, who will be talking about a sort of an overview on diabetes and cardiovascular disease. Welcome, Dr. O'Connor, and if you will just tell us a little bit about you, and then the floor is yours.
Terrific. Good morning. Thank you so much for having me. I'm honored to be here. My name is Jean O'Connor. I'm the Chronic Disease Prevention Director at the Department of Public Health, and I'm going to be speaking with you about diabetes and hypertension, and giving you a little bit of an overview of what we do in the department. So I'm just going to pull up some slides here if that's okay. And I have one of my colleagues here with me as well, Allison Smith. Allison, would you wave your hand, please? Allison is our Diabetes Prevention Program Manager in the Department of Public Health. And in our section, the Chronic Disease Prevention section of the Department of Public Health, we have responsibility for the statewide programs that pertain to all the things you might think of when you think of chronic disease, including tobacco use, cancer, diabetes, hypertension, asthma. We also have responsibility for teen pregnancy prevention and several other programs, including nutrition and physical activity. I came from our meeting of providers who are going to be working with the Department of Public Health and the delivery of the SNAP education program in collaboration with the Department of Human Services. So I apologize for being a few minutes late. What I'd like to do with you, if it's okay, is just give you a brief overview of the burden of diabetes and hypertension in Georgia, talk with you about some of the tools and approaches that can be systematically used to prevent and control those two, discuss our goals, services, programs, and partnerships in the Department of Public Health around these two issues, and then talk a little bit about some of the ongoing opportunities to connect these issues to the broader set of health systems transformation and quality of care considerations in the state. If that is okay with the committee, I'll go ahead. Perfect. Thank you. Well, so I probably am sharing with you something that you already know, but Georgia has among the highest levels of cardiovascular disease risk factors in the nation. You see two maps here. The top map, I know it's a little small, is men and the distribution of cardiovascular disease risk for men. The bottom is for women, so you see the risks are slightly higher here for men, but that we're similar to many other southeastern states. In fact, we rank about 40th. 41st, we bounce around there as compared with other states on overall health outcomes. And so diabetes and hypertension are two of the top 10 leading causes of premature death here in our state. They are both preventable and treatable, controllable conditions that contribute significantly to our overall state disease burden. They do both have common risk factors, which of course with so many physicians and healthcare providers here in the room, you know this. But tobacco use and secondhand smoke exposure, being overweight or obese, poor nutrition, lack of physical activity, and excess alcohol use all contribute to both of these two conditions. And of course, there are social determinants of health that contribute to risk for these conditions as well. Low income, low education, and race and ethnicity all play a part in our state in these conditions. There are several evidence-based interventions that can be used to address both. We look to a number of different resources in the Department of Public Health, including the Community Guide, which is put out by CDC. It contains sets of evidence-based interventions that can be used for different chronic conditions. The U.S. Preventive Services Task Force as well releases guidance and guidelines around these conditions. Primarily, those are directed towards clinicians, and the Community Guide is directed towards clinical and community providers. We also have been working actively here in Georgia with CDC around something called the 618 initiative. That's the picture you see on the lower right. That's an initiative, a national initiative, and Georgia was one of the first 9 states to participate to address the 6th highest cost health conditions in our country, and indeed they're the same 6 in Georgia, with 18 evidence-based interventions. So Georgia has been participating. In its first year, we focused on asthma and teen pregnancy prevention, long-acting reversible contraceptives as well. And this year, we're focusing again on asthma, but now working on diabetes with CDC. So we're very excited about that. As you look across all of the evidence that's out there, and there is very much to sift through, so that's part of what we do in the chronic disease section at the Department of Public Health. There are a couple of recommendations that are really at the top of the list. That's annual screening for hypertension for anyone over the age of 40 should be screened. Medication adherence initiatives, things that promote medication adherence for hypertension, very important. And there are payer strategies that can be used to promote medication adherence with patients, right? There are things providers and payers can do. Team-based care, which includes all healthcare providers really working at the top of their license. If you think about it, of course, right, a nurse or an LPN can take a blood pressure. If someone needs their blood pressure checked on a regular basis because they have hypertension, we really advocate for people to have that access in their communities through whatever provider working at the top of their license can provide that access. So we think that's important. EMTs, which I am a former EMT, can also provide that service in communities. In terms of diabetes and evidence-based interventions, there are a few also at the top of the list that we work on. Screening for diabetes for anyone ages 40 to 70 who's overweight or obese. This is a newer recommendation. It's something that we find not all providers are aware of. but it's very important, and so we're out communicating about this across the state. We also have been working on some initiatives around diabetes self-management education, sometimes called DSME or DSMT. This is something that not a lot of people have necessarily heard about here in Georgia, but it is being used across the country. This is a program that is paid for if you are a Medicare participant. It's essentially group with a little bit of individual self-management education. It teaches a person who's been diagnosed with diabetes how to manage their diabetes. This is something that we know we don't have enough access to across the state here in Georgia. The accredited DSME programs that we have in this state are primarily concentrated in the metro area. When you look at who has diabetes in this state, if I had shown you a map, and we could have spent a long time talking about that data, but you see the rates are much higher in South Georgia, particularly for hospitalizations, and I'll come back to that in a few minutes. And then the last intervention is the diabetes prevention program, and this is really for anybody who does not yet have diabetes but has any of the risk factors for diabetes. This is also something that the Medicare program has announced it's going to pay for. The payment for that is going to start in 2018, and that's a year-long program, intensive nutrition and physical activity opportunities, group support, and it's something that can be done in a variety of clinical or non-clinical settings. Again, an area where we think there's greater need in the state, and I'll show you some data about that in a minute. We have been working in this area for a number of years, thanks to the leadership of Dr. Fitzgerald and now Dr. O'Neill. Diabetes and hypertension do appear in our department strategic plan. They also appear in the statewide health improvement plan. We have essentially a goal to reduce preventable hospitalizations associated with both of these conditions. And we're very grateful for the new funding that we received last year that helps support a position to work on diabetes in the department from the legislature. And we have been working on a number of things, including we provide funding through a federal grant to 5 of our health districts to offer clinical services around diabetes and hypertension. We provide small amounts of funding to health systems, so private health systems, to do quality improvement work across the state around both diabetes and hypertension due to another federal grant. We've hosted health systems quality meetings for both public and private providers to talk about how they can improve the quality of care and access to the screening that I just described. We have some nurse protocols in DPH, which we're very proud of. They're new, very state-of-the-art, that let our nurses serve patients with both conditions, and we're really just getting that work up and going. We also have a partnership with the Pharmacy Association to get the word out to pharmacists to train them to do the parts of these services that they are able to provide. We work with DCH and CDC, as I mentioned, on 618, and we're doing extensive training across the state on DPP and DSME, and that's part of what Allison works on, so if you have questions about that, we may be able to answer them. And we have some pilot projects with the CMOs, and in December, we're pleased to announce that we're going to host a statewide diabetes engagement meeting, really to bring together all the community partners, academic partners, clinical providers, and others who are interested in becoming diabetes prevention program providers. I mentioned that training. This is just a graphic with some of the numbers of folks we've trained. These numbers are going to continue to increase pretty dramatically this year, particularly around the number of DPP coaches trained, and we hope the number of accredited DSME sites in the state. We've been working, as I mentioned, with one of the CMOs, and this is some data from AmeriGroup, who chose to pilot a diabetes self-management education initiative with some of their Medicaid members. So DSME is not reimbursable currently in the Medicaid program, but they chose to pilot it anyway, and they got some really terrific results with their diagnosed diabetic patients at one area hospital. They saw some pretty significant decreases in A1C in those participants. We also have been partnering with Emory University. We asked them really where in the state might we work if we were trying to gain the greatest benefit in terms of control of diabetes as well as hypertension. So you see the authors listed here: Shivani Patel, Irene Blumauer, and Venkat Narayan. Venkat is very well known globally for his work in diabetes prevention and control. And so they helped us ask the question, where might we get the greatest benefit from expanding that diabetes prevention program? And where would it, which counties were most in need of hypertension control initiatives as well? So they took an approach that's somewhat detailed, and I'll just sort of walk you through this at a high level. But essentially, they used a methodology to identify patients, proportion of patients or the population at risk by county. They looked at a number of factors, things like adult obesity, diabetes hospitalizations, and hypertension hospitalizations. And they estimated really the prevalence or proportion by county, or where they had to by health district. They made a rank, a county risk score. And this is really what they found. In terms of the geographical distribution of individuals with highest diabetes risk, the blues and the purples, the darker the color here on this map, the greater the number of individuals with greatest risk. And what you can see is we have a fairly high risk across our entire state. It's interesting, though, because here when you look at raw numbers, you primarily see the north part of the state. When we look at hospitalizations, we see greater rates in the south. And by the way, hospitalizations for type 2 diabetes are almost entirely preventable if the condition is controlled outside of the hospital, of course.
Do you mind if I interrupt you for a minute?
Yeah.
Because you're getting three legislators over here going, what? This would be in direct opposition to what we have thought and where this risk was. We would have thought it would have started over in the Columbus area and come down, across our state over into the Alabama area.
So this is a slide of people at risk of diabetes. If I were to show you a slide of people with diabetes, so the people with diabetes are going to benefit from self-management education programs the most. They've already been diagnosed. The people at risk are going to benefit the most from prevention programs. So the diabetes prevention program.
Right, but they're not in the same areas?
They're not in the same area. And so we really have, that's actually part of why I wanted to show you this slide. We really have two very different sets of things going on in the state. In the north part of the state, we have great numbers of people at risk of diabetes. In the south part of the state, the epidemic has really taken hold, and we have people who have already progressed to diabetes. So there are two different sets of needs in the different parts of the state. And it's almost a diagonal line from Augusta, Athens down across to Columbus that divides the state in half. We see a similar pattern when we look at hypertension as well. Okay. So I'm going to just focus for a minute on the prevention program because this is where there's probably the potential for the greatest savings over time in health care, in the healthcare system with increased access. Although obviously there's the need in the people who have already been diagnosed with diabetes. But in this prevention side, and I realize folks in the audience can't see this, so I'll tell you what it says. It tells us the expected number of cases of diabetes over time with no implementation of the diabetes prevention program. And they estimated over a 4 or 5 year period of time, 43,000 new cases of diabetes if we do nothing in the state. If we were to achieve 100% coverage for the DPP program, we would see that estimated number of new cases reduce by about 20,000. So we'd only see about 24,000 new cases of diabetes. And then they did some subsequent estimates you see off to the right-hand side of the slide, which is if 50% of the population had DPP or 25% of the population had DPP.
I had a minute to think about this in my mind. This was potential, and we saw where those areas were, and we can't just assume in the white area that seemed to be the area where we've already got it. So basically, the whole state is basically on the road to diabetes.
Yes, our
I mean, there's almost nothing.
current rate of diabetes is about 11 We've seen some projections, of course there's some variation in these projections, but that if we do nothing by about 2025, we'll have about somewhere between 20 and 25% of our population will have diabetes. Right now, 1 in 3 adults in our state have hypertension. So these two things are truly at epidemic proportions, and clearly there are some access issues here in our state to both the prevention and the control programs.
Okay.
So our colleagues at Emory also created a composite score and looked at where the 10 most vulnerable counties were, because I said we have limited resources in the Department of Public Health and in the state. I can't probably come up with programming to work statewide. So if I had limited resources, Venkat, where should I go? And so the response they gave me were these 10 counties listed down the side: Macon County, Peach, Dougherty, Turner, Clayton, Worth, Bibb, Dooley, Wilkinson, and Bacon. This is in terms of both prevention and control types of initiatives. They essentially, I said, if we took everything we had and could put it somewhere, where should we put it? So this is the list they provided me. And some of the way they did this math, I think I'd probably have to have them explain a little bit above it. But again, Venkat does this work globally and I think did an excellent job. There is a more detailed report. I just want to mention this if you're interested, because I can hear some folks in the audience whispering about this as well. If you'd like to read the full report and not just see the slides, you can get to it by going to dph.georgia.gov/diabetes. The report, the slides, and some other materials are toward the bottom, as well as our diabetes action plan, which we wrote about 2.5 years ago for the state. So those are some of the data. These are where the existing DPP programs are, and I'm happy to make these slides available because I'm sure people probably cannot see that across the room. What counties they're in. Bottom line, they're not in the highest risk counties. And so that is something that we are going to be working on through the diabetes engagement meeting that we're holding this fall.
We get a lot of paper, so if you could provide your comments and your slides to the committee members, and then if they want to go deeper, they can.
Great. And then, so the last sort of point I'd like to just make is around that the potential of both the diabetes prevention program and the other evidence-based interventions I described, we really find through working with our health systems partners that it's most helpful when these things are viewed in the context of larger sort of systems changes. Of course, all of you know that our healthcare partners have many things on their plates, including many federal regulations. And so when we talk about these interventions, they really appreciate it, or seem to appreciate it, when we line them up with the other things that they're responsible for, including all those performance measures they have to report on to their payers. So we all know the healthcare system is going through a bit of an evolution from sort of episodic non-integrated care to what we hope is eventually community integrated healthcare with both community prevention as well as clinical prevention. We hopefully all are aware of the triple aim concept, and we find that more and more many of our health system partners are talking about that. So we again try to put some of these interventions into those contexts to improve population health, reduce per capita costs of care, and improve the experience and outcome of patients. And we find that's why groups like AmeriGroup, even though they were not being reimbursed, wanted to try this, because they were really quite motivated to improve their performance on their Medicaid contract and to help their providers improve their performance as well and the quality of care. And they also wanted to reduce costs. And I have some documents that I'll hand you that do outline the cost savings associated with some of the interventions I just described. But this is something that we're really pleased that the healthcare systems and our public health departments across the state are giving some thought to. We try to link our community and clinical prevention initiatives. We do work on both of those things in the department because we know what people eat, right? How much physical activity they get is probably more important in many cases to their long-term health outcome than immediate sort of acute clinical care. we try to implement these evidence-based interventions, and we're building partnerships actively across the state between public health and healthcare. We're really trying to support communities and hospitals that are thinking about innovation and financing. I'm sure the committee will hear from some of those facilities at some point, and to support them in their quality improvement initiatives, because there is so much happening in the federal payment world. They're responsible for reporting on so many things that we found that offering support generally around quality improvement initiatives is something that the health systems and providers have told us is useful. We also try to, of course, promote community engagement. When you have engaged participants in a community, these prevention initiatives and control initiatives that I described, we find work so much better. We have a great example happening down in Douglas, Georgia, in Coffee County. These help promote patient engagement as well. And then, of course, collective impact strategies. One of the key groups that we're hoping to bring to the diabetes prevention conversation here in the state is actually the employers. Many of the employers in South Georgia, folks who employ people who may have to have commercial driver's licenses or operate other machinery, they're really very motivated, they tell us, to try to help be a part of addressing these epidemics, because they, of course, then can't afford those workers if they can't come to work and do their jobs. If their blood pressure is out of control or their blood sugar is out of control, they're not eligible to perform any of those functions that are needed in so many companies across the state. So this is my contact information, and I'd be pleased to answer any questions the committee may have.
Okay. We have questions for Dr. O'Connor from the committee. Okay, just turn your light on. Who we got right here? Dr. Felzine?
It's good to see you, Dr. O'Connor.
Hi.
I've got one question, and then following your answer, I've got a follow-up comment. And I'm assuming this question is going to be pretty much for every presenter that comes through, just because, as you know, I'm in the field throughout Georgia quite often with my job at DPH. And over the next 20 years, it's really predicted that the amount of information that's going to be available is going to be astronomical. And it's really going to be us as providers and practicing in the fields, it's going to be like drinking from a fire hydrant. And we've all heard that before in the past. And my question is as diabetes and hypertension, these guidelines change so rapidly. And when I'm out in the field, I see providers that are usually 2 or 3 guidelines behind in their practice, and trying to get information out not only to the folks that are in the trenches. We have vast turnover in rural areas of these providers at all levels: nurses, nurse practitioners, physicians, the whole gamut, mental health providers. We also have ERs that are they're contracting out to medical groups that are out of state. We have prison systems that contract their medical from out of state. So my question really is how are we effectively reaching out and getting this up-to-date information and trying to make sure that our providers are giving standard of care to the clients we serve?
Yeah, I think we have a number of things happening to try to reach providers across the state. It is true that it is a little easier, although not entirely, to reach the larger systems where they have internal sort of communication mechanisms. They may use an electronic health record with prompts and so forth. They may have protocols written for their providers that they have more ability to keep up to date and retrain internally. We do find with the smaller solo practitioners that it's harder to reach them. They are being bombarded with so much information. They don't typically spend a lot of time in front of their computers. It's harder to reach them. One of the things that we have done and did for the last 2.5 years, it's wrapping up now, is that we were holding lunchtime, what our partner at Alliant Quality, the quality improvement organization designated by CMS for the state, called Quickeners. These were 15 to 30 minute lunchtime webinars that were also phone-based. So providers, and they were really geared actually towards the office staff primarily, who might be working on billing, sort of payment or patient flow, but also providers. And we were providing CEs for those. Nurses also and pharmacists could listen to those and hear what we thought were some of the most urgent sort of key issues around practice, potential changes in practice for diabetes and hypertension. Immunizations was also in that mix, and a few other issues. That group is a really informal group of the provider organizations across the state, like MAG, like the College of Physicians, the Family Physicians, the Hospital Association, and they call themselves, DPH was involved, they were calling themselves the Georgia Clinical Transformation Team. Essentially, this was an initiative where people were bringing their different resources to this conversation, because we do have other funding that comes into the state for quality improvement in healthcare that does not come through DPH or DCH. It goes directly from CMS, for example, to Alliant Quality, which is that nonprofit quality improvement organization that works with physicians. The Hospital Association also has a practice transformation network grant from CMS that they called Compass PTN. So they were working with 1,000 providers across the state. So we're really trying to sort of harmonize our messages in a voluntary way. And I think, I don't have a lot of data to support this, but I think that was a success in building relationships between the organizations and also trying to get on the same page about what we were saying. Because of course the measures vary between Medicaid, Medicare, right, and private payers around what are you supposed to worry about A1C? Are you supposed to worry about, numbers of visits? What are they most concerned with? And so we were trying to harmonize our messaging. That was one way that we've been trying to work on that question.
And I can actually give you a significant amount of data. 17 years ago, Dr. Sanjay Arora had the same issue in New Mexico, and he developed Project Echo. And what this did was exactly what you had described, in bringing an understanding that when you have a face-to-face, and now with expansion of telehealth, which we've done exponentially here in the state, that affects one individual, which is great for that individual, but doesn't necessarily affect systems. And the Echo Project and what you had described really affects systems. And there's now growing data that shows it's cost-effective, it increases standard of care, it decreases gaps in services, and it brings communities together in what you just described, that somebody in a rural area may not have the resources, but somebody else that's part of that project may have advice and be able to communicate and assist them in doing that. So I'll be happy to talk with this more offline if you're interested. It's an international now. It's in, I think, 12 countries, and the service itself is free. There's just some other costs, startup costs, which the state of Georgia has already paid for in Ms. Salgado being able to get telemedicine throughout the state. So we're a step above most places and anybody else who has questions. And I just mentioned this because some of the other speakers, I'm going to have kind of the same comments of using these type of platforms, which are very cost effective.
And telehealth and bringing medical educators together around some of these issues, we also believe could be quite helpful, but always, of course, looking for next steps. So thank you.
Thank you. And I hope you'll follow up between the two of you. That's one of the things, sharing information.
And just one last comment, if it right. So my last comment with what you just said is a lot of times with these committees, we want to try to bring people across the state together because we have folks in Fulton County, DeKalb County, which are fantastic providers, but they understand urban care and do not necessarily understand rural care. And I've had some urban providers call me and said, wow, that was a different bird.
Yeah, it is different. Representative Bennett. Representative Bennett.
Thank you, Madam Chair. Thank you, Dr. O'Connor. This, amongst other health issues, are quite massive. And yet it seems as though you've got a good handle on approaching it from several different perspectives. You mentioned the health rankings, however, in Georgia still remains low at 40, 41. Are there any goals or targeted benchmarks that would direct us or are encouraging us that we're going to see an improvement in those rankings?
So we have some examples here in Georgia where when we have brought people together and really made a concentrated effort over time, we have moved the needle on different health outcomes. I think, early elective deliveries is one that many people at the Department of Public Health would cite as an example where when you bring folks together, you can really almost eliminate a problem. I don't have those data off the top of my head, but I've heard the stories enough from various folks and from the Hospital Association to know that we really made huge progress in a short amount of time in that area. Tobacco is actually another area where we've made a lot of progress in this state since 2001. We have a quit line, which is very successful here in the state. And while there's always more we could do to protect people from tobacco, rather than rank about 40th in the measures used for tobacco, we actually rank in about the middle. So we're doing better than more than half of the states when it comes to cigarette smoking in the state. And I think that's really thanks to a lot of work that's been done over a long period of time in partnership with the Department of Education and the Board of Regents to create tobacco-free places and to really get the message out about the dangers of cigarette smoke. So that's an area where I think we have made progress and could look to for some examples. I do think that it is truly possible to make very significant progress in reducing the rate of hospitalizations for type 2 diabetes and to prevent new diabetes cases. Hypertension's a little harder because there's a genetic component to that, but I think in hypertension as well, we could prevent hospitalizations for hypertension if we made a concentrated effort to really implement these evidence-based strategies over a period of time. So I wouldn't be standing here if I didn't believe that. And so I hope that if we could talk more about that at some point, I would be delighted to.
Okay.
Thank you.
Dr. O'Connor, thank you very much for coming. I don't have any questions lining up. I would like, and I know that you're busy too, but one of the things we'd like to know is, now, other than funding, which, we don't have the ability, other than our one votes on this committee, to raise the funding, if there are any impediments through regulation or our laws that are state laws that would enhance what you do in these, we'd like to have before this committee ends in November. We would like to have the suggestions. If you have some where it might make a real difference. And so
I'd be glad to take that back. Our government relations director was here in the room. He may have stepped out, but David Bain, to take that back and see if we, as program staff, can identify any of those things. In addition to funding, the other thing I would say off the top of my head, though, is that engagement in leadership is really a significant issue. I mean, to address diabetes, I think we have to have folks at a leadership level, at the county level, city level, and in organizations and in the legislature believing that we can do this. If we can bring enough folks to the table who are interested in learning about these initiatives, diabetes prevention program, I've done some rough math, and the diabetes self-management education program are at least partially totally self-sustainable in provider organizations if they can get enough volume of Medicare patients as well. So these are things where really it's about getting it up and running and getting folks some experience with them rather than about state dollars to fund ongoing programs.
Okay, this raised a couple of questions, and we'll take them before we go on. Dr. Walsh?
Yes, and thank you, Madam Chair, and thank you, Ms. O'Connor, for your presentation. One of the question, one of the items that physicians are dealing with right now is the MACRA and the MIPS requirements to bring us into this area of quality measurement. My heart goes out when I hear comments like the one you made that maybe some of these efforts they can't be reimbursable. So it's hard to sometimes structure or put together the team that to be deployed to address these issues. My question is, are you aware of in that advanced planning model, is of MACRA, and maybe there's some opportunity at the state level too, with the concept of that advanced planning model, like the medical home, whereby it might be better structured to be able to put together that team in a way that those efforts could be reimbursed.
Yeah, I think, so, we have some interesting things happening because Medicare, again, will reimburse for hypertension screening, for diabetes self-management, and for the diabetes prevention program. But currently, the Medicaid program here in Georgia does not reimburse they do for hypertension screening, but not for the self-management education or for the prevention program for diabetes. So, we have different things happening in different populations, but in the same geographic area in our state. So I know that poses challenges for providers, different kind of care for different patients that come in the door, makes it hard, we hear, to operate your practice. And so reimbursement is a key piece of this picture. The other thing that idea that has come up, I'm not sure if this is a direct answer to your question, but is the thinking about this geographically. In other words, if we can't fully fund implementation of this in all places across the state, could we use some sort of regionalization to create models that could help facilitate, like the Project ECHO concepts, maybe a hub for diabetes prevention in each of our health districts, and then some of this can be delivered actually over telehealth. So are there ways to support providers to ensure these interventions are available, even as they continue to work through some of those payment models that we don't have full control over? So some of those things are things that we're talking about, and I'd be delighted to kind of take that one back too and talk with folks. And we have an expert in MACRA in our group, and see what she has to say as well about that.
And thank you.
Dr. Graham.
Yes, thank you, Dr. O'Connor. Very interesting presentation. And, we talked about the differences that we see in our state between North Georgia and South Georgia. And, with limited resources, I know that often we look at targeted interventions. And, I would just argue that it certainly makes sense based on the data you presented that we would target education or prevention in North Georgia and the self-management education maybe in South Georgia, but we know that 5 to 10 years from now, that population in North Georgia will convert. And so I think we really have to look at targeting both subsets of population with both prevention and the self-management education at the same time. So that's one point. The second point was just wondering if you're familiar with the Adverse Childhood Experiences study. And for those who might not be, it was done by Kaiser, large study looking at risk factors, health risk factors associated with adverse childhood experiences and things that contribute to that. And it clearly showed that we need to intervene much earlier than once people are identified as being at risk for the health factors, but really looking at issues of poverty, access to resources, exposure to violence and trauma in those populations, increasing morbidity associated with those long-term outcomes.
We would absolutely agree with that. And the meeting that I was at this morning, the kickoff for the SNAP education work, we were really talking about risk factors for overweight and obesity, which are, of course, the precursor to type 2 diabetes. They're precursor to hypercholesterolemia, and in many cases, hypertension. People have that whole cascade, right, of diseases that ends in death from a cardiovascular condition. But we know that obesity really starts in childhood, and the Governor's SHAPE initiative, which I didn't talk about, is very important piece of this picture, as well as access to healthy foods, which is not something people all across our state have. So there's a lot of work to be done, and we would absolutely agree with that there are populations with much greater need of these interventions, within counties and across our state. So absolutely, thank you for that comment. Yeah.
Dr. O'Connor, before I go to the next question, I'm going to take credit for the SHAPE program, not for myself, but for Soap Creek Elementary in my district. The program is based on Soap Creek. They had 4 years of study showing, and they didn't do it for obesity. They did it because they showed that by having 30 minutes of activity in the morning, that their math scores and their science scores increased significantly, and behavior problems went down the other way just as much. And Commissioner Fitzgerald and then the First Lady both came, and that was the foundation of the program. I'm very proud of Soap Creek, and that was an initiated by a principal and the PT department there, which says that we don't have all the ideas here, that they come from that kind of program, and I would like to see our legislators and people bring them to us. Sometimes the best things come from out in our community. Dr. Price.
Perfect segue. Thing here.
You're on.
Okay, perfect segue into my comment, which was looking at that North Georgia, where they were like maybe say pre-diabetic or somewhere on the continuum, based on the risk factors. Maybe we ought to look and see what they're doing that's keeping them at the left side of not progressing to more advanced disease.
And we think we have some ideas about that, but we can certainly go back and give you a definitive answer. There's some significant differences in race and ethnicity between North and South in terms of proportion of the population that's white or Black or African American. We also know there are some significant income differences as well, and we think that there may be, if we were to also look at access to care factors in terms of geographic proximity to a healthcare provider, we know that in North Georgia there is more geographical access than in South Georgia. So we think there are probably a couple things going on, but I'd be glad to take that question back and see if our colleagues at Emory can work some math and some magic with the statistics and come up with a definitive response in terms of at least what they see in the data that they have right now.
Yeah, Representative Hawkins suggested it might be the moonshine.
Oh.
And the wine.
Okay, thank you, Dr. Kerner. We need to move on. But the one thing is, what got me was the medication on these, whether people don't take their medicines because people do not like to take long-term medical programs. I think it made quite a difference in HIV when we moved from having to take 30 pills a day to where they could take 1 or 2. They found significant more adherence, and I think that but I would like to tell you, and if you'll take it back to the Commissioner O'Neill, please. The state now has, and it's beginning to start short, a program of recycling unused meds. They have a pharmacy in Gwinnett, and now are up and ready to ship medications across our state to people who cannot afford them. And they're slowly trying to get this out. Apparently they have a little questionnaire, but they don't push people. It's not long and involved. If they can pay a little bit, they ask them to pay a little bit. If they can't pay it, it's free. They will ship it to them. So and that is recycling medicines, no narcotics, nothing that has to be refrigerated, and it could be a problem. But things like insulin that is so expensive to buy and is sent back to the companies if it's within 6 months of expiration date, the pharmacies won't take it, and destroyed. So my office can get you the name of the company, and if we can some way get that name out, and I will get it for another meeting. They started off slowly with some of our federally qualified health centers in various parts of the state, north, south, and so forth, but they are ready to kick it off and are fixing to kick off a campaign to let people across our state know about them. They've come up with a new name. It used to be called Serum. When it was done in some states out west, but they decided they needed an individual name to meet with our state laws, and that will be available for people to access.
Fantastic.
So hopefully that will be very helpful, and if it is a matter of not being able to afford medications, why they don't adhere, certainly will not help in just the fact, I have trouble remembering to take my thyroid in the morning, and I've been on it for years, so it won't take care of that, but if it's a lack of money, hopefully this would be a thing. Thank you very much for coming. We really appreciate it, and if you'll take back that message, work on what I asked you about, and we've given David, he was here again, he's gone, so to find that for you.
Thank you.
I want some information back, David, and some of you. Thank you. Okay, well, let's move on. We're moving on to COPD, asthma, and severe asthma. Dr. Walker. Thank you very much again of giving your time and coming. And I'll say here as you're coming up, thank you to the committee, to the physicians, and everybody willing to drive here and give up time from your practices and what you do. Thank you. And the committee is selected by, and I have to thank the speaker. The speaker decides which committees can go forth as we make bills for them. The speaker did decide this was of value, and the speaker picks the committee members and who we might invite to serve. And I am very appreciative of the speaker and the people he's chosen and allowing this committee to go forth. Dr. Walker.
Thank you, Madam Chair. My name is Seth Walker. I am a pulmonologist at Emory University, certainly see lots of COPD, and would like to talk to you about what COPD is, so we have a common base of knowledge, talk about the impact of COPD on the state of Georgia, talk about barriers to care, and if I could be so bold as to give some suggestions of what we may be able to do.
That's what we want.
Excellent. Chronic obstructive pulmonary disease, or COPD, is a common and preventable lung disease that's due to exposure to noxious particles or gases in susceptible patients. The number one cause worldwide is tobacco smoke. We don't seem to find any population that's really immune to this, but there are some people that seem to be at higher risk. Also, indoor air pollution is a cause of COPD. So this isn't entirely tobacco smoke of people who are actively smoking. Environmental smoke can be a problem as well. So children that grow up in homes with cigarette smoke can be at increased risk of developing COPD later in life. Additionally, in many parts of the developing world, we see biomass fuels, so people that cook with wood or coal or other sources are exposed to that, both heat and cooking, can develop COPD. There are certain chemicals as well, many chemical solvents used in the manufacture of even carpets can be associated with COPD. As I said, susceptible patients, we aren't completely sure if there is anyone immune to COPD, but we do know that there are certain populations that have an increased risk of COPD. Women are among them, that women who smoke, even though in general they tend to smoke less than men, tend to have an earlier onset of COPD and more severe disease. Asthma is also a cause, especially patients who have severe and uncontrolled asthma are at increased risk of developing COPD. There are some patients who have an inability to balance breaking down tissue and building it up. The most commonly known deficiency is alpha-1 antitrypsin, but there are probably many others that we haven't yet identified. And so these patients are going to be an increased risk. Also, patients who have abnormal lung development. We've found through some sophisticated studies that if we do lung function testing in babies, which is quite onerous but can be done, that there are not babies that all have normal lung function, that there seemed to be a separation. And if we separate them into tertiles, the first and second will go on and be indistinguishable by the time they get to adulthood, and they've got normal lung function. The lowest tertile will never reach normal lung function, that their lung function lags behind the other two. So there could be patients who are born with abnormal lung function, a third of the population at risk for COPD, perhaps with less exposure to noxious particles.
Third?
A third. The injury from these noxious agents leads to inflammation that even once the noxious agent is removed, the inflammation does not go away. While this is in the airways and in the lungs, it can actually spread to the rest of the body. COPD is a systemic disease. The inflammation leads to collapsible, narrow airways, excessive mucus production, and destruction of the air sacs that allow oxygen to reach the blood. This leads to symptoms of shortness of breath, chronic cough, which oftentimes is productive Patients can be troubled by bringing up a copious amount of sputum, the incessant coughing from sputum that is lodged in an airway and cannot be expectorated, and also chest tightness, which they often describe as a heaviness or a pressure on the chest. I don't know who's ever had an elephant sit on their chest, but that's often the term that we've heard. Patients become disabled due to the shortness of breath as well as an oxygen need. The lung function declines normally in patients, and I hate to be the bearer of bad news, but probably physiologically we peak at 25. So we're all on the downhill slide.
Speak for yourself.
But lung function continues to increase from birth to the mid-20s and does not plateau. It begins to decrease after that. The decrease is minuscule. It's really not going to be noticeable. You won't be able to run as fast as you could when you're 60 as you could when you were 25. But this makes COPD a progressive disease, even in patients who have stopped smoking. And so the lung function that's lost from the smoke exposure, the noxious particle exposure, will progress and will do so much faster in patients who continue to smoke. So that's certainly an area where we need to focus efforts is on the patients who have COPD but continue to smoke, and Dr. Foreman will speak more about that later. The disease can acutely worsen with exacerbations, and these require a more intense treatment and oftentimes hospitalizations. And this leads us to the burden of COPD in Georgia. And just as an overview, in 2004, COPD was the fourth leading cause of death in the country, well behind stroke. And it was predicted that by 2020, it would become the third leading cause of death. It took 3 years. In 2007, COPD surpassed stroke as the number 3 cause of death in this country. It is the third leading cause of death in Georgia and causes about 4,400 deaths in 2014, according to the latest year of data from the CDC. Again, showing us a worsening problem. From 2004, that's an increase of more than 1,000 people that have died a year from COPD. Nearly 500,000 Georgians are affected by COPD, but this is likely an underestimate. COPD patients often do not present for evaluation and for diagnosis until they've lost about half of their lung function. Oftentimes, as this tends to be a disease we notice in an aging population, people say, well, I'm getting a little short of breath going up the stairs because I'm getting older. And then it's like, well, you know, I just can't do what I used to. And then at some point they realize the people their age can still do these things and they can't. And that's often when they've already had a significant decline in their lung function. The direct medical costs are almost $900 million to the state, of which Georgia Medicaid pays about a fourth of that. Indirect costs are harder to estimate, but we have to consider that some patients are still working, and so there will be absenteeism from work. And also in patients who might be older or can no longer work, there may be absenteeism for their caretakers, for other family members that have to look after them. In Georgia, there are about 8,500 admissions a year to the hospital, just in patients over age 65. It's the fourth most common cause for admission in 65 to 74-year-olds, and in 55 to 64-year-olds, it's the sixth most common cause. In both age groups, it's one of the most common causes of presentation to the emergency room. So even patients that aren't admitted are still having excessive costs for emergency room visits. There are treatments for COPD. One of the first and most important is smoking cessation. While we have treatments, they will be poorly effective in patients who are continuing to smoke. I explain to patients that I can prescribe lots of medications, but it's akin to trying to wash your car with sewage. It doesn't matter how much soap you add, it's still going to be dirty. No matter what medicines you're on, if you're still smoking, it's not going to work. Many of these medications are inhaled. We have bronchodilators, including long-acting bronchodilators. These are medications that help open up these narrow and collapsible airways and allow patients to move more air and feel more comfortable. They've been shown to improve symptoms, decrease exacerbation rate, which keeps people out of the unscheduled doctor's appointments, out of the ER, out of the hospital, and also decreases hospitalizations. The problem, though, is that oftentimes access is difficult because they do tend to be expensive medications. And while many of the medications will work well for a lot of patients, there are idiosyncratic responses. Some patients will not respond well to one versus another. And sometimes due to formulary plans, it's difficult to try and find another one when people do not respond well. There are some oral medications. Azithromycin is a macrolide antibiotic that we've since found has significant anti-inflammatory properties, especially in the airways. So there are many diseases where we've used azithromycin as an anti-inflammatory. And in patients with more severe COPD who have frequent exacerbations, this has been shown to decrease exacerbation rate and keep patients out of the hospital. One of the barriers to using this seems to be that there's a quantity limitation. Most insurance plans still look at it purely as an antibiotic. And so you're allowed to have 5 or 6 pills. And if you're supposed to take this every other day chronically, it's hard to try to justify the trips to the pharmacy and the excessive copays for this. Additionally, there's a medication, roflumilast, that works as an anti-inflammatory in the airways. And in patients that have chronic bronchitis, the excessive cough and sputum production in COPD, who have frequent exacerbations, this has been shown to decrease the exacerbation rate and keep patients out of the hospital. Again, one of the issues has been the cost and how well covered it is by plans. Additionally, in patients who have significant desaturation, significant hypoxia at rest, chronic oxygen therapy has been shown to improve mortality. Patients will stay alive longer when they are able to use that. One of the other very inexpensive issues that patients cannot really have an adverse reaction to is pulmonary rehabilitation. This is a program that provides some education, not only talks about different breathing techniques that patients can use when they feel more short of breath, but also starts them on a supervised exercise program. And patients who undergo pulmonary rehabilitation with COPD notice a better quality of life, have decreased exacerbations, so coming to the doctor, coming to the ER less often, and stay out of the hospital more. One of the issues with pulmonary rehabilitation, and we'll talk a little bit more, is access, but also the benefits that you get go away if you stop exercising. So continued access to a place to exercise can be an issue for some patients. To speak more about the barriers to these treatments, one of the first typically is poor access to providers for diagnosis and appropriate treatment. There are recommendations that smokers, certainly smokers with any respiratory symptoms, undergo spirometry, lung function testing. That would be how we would identify COPD. Many clinics, I imagine, in rural areas may not have access to this. And so this may delay diagnosis. In rural areas, there's also going to be a paucity of pulmonary specialists for patients to receive more up-to-date treatment as well, perhaps even as diagnosis. Also, as we mentioned, the cost of medications. Not only is there a cost, if patients do not respond well to a preferred therapy, it is very difficult to try to get a non-preferred therapy for them. Even though it may be in the same class, it may be equivocal as far as efficacy. And that often is an obstacle that we have trouble getting around. Insurance coverage for pulmonary rehabilitation is also a problem for many patients. The U.S. Congress several years ago passed a law stating that Medicare would cover pulmonary rehabilitation for patients with moderate to severe COPD. However, not all insurances have followed their lead. And so some insurances require restrictions on pulmonary rehabilitation based on lung function, not necessarily on exacerbation rate or utilization of resources. And sometimes some insurances will not cover it at all. Additionally, pulmonary rehabilitation may not be available in every area. Georgia is a very large state, and there are a handful of programs. So if you live in an area where you may have to drive an hour or 2 hours to get to the location for the rehab program, where you should be going usually 2 to 3 times a week for several weeks, we run into transportation and access issues there. Now, to change pace and show how things should look, what happens when COPD care actually works, I would like to use an example of one of my patients, RC, who was a gentleman in his late 60s, who originally presented to me with worsening dyspnea that was really leading to disability. He really could not do much of anything, had always been an active man, but was finding it difficult even to walk around his house. We were able to start him on a regimen of long-acting bronchodilators, and he noted significant improvement in symptoms. I also started him with oxygen and pulmonary rehabilitation. With this, he noted a marked improvement, was very pleased, and actually felt like he was no longer limited in his activities. Unfortunately, after a year or so, he developed several severe exacerbations requiring hospitalization, and despite aggressive treatment, he had not returned to his baseline functioning. One of our concerns was that a lot of the inhalers that are used require a certain flow rate. You have to have enough lung function to generate force to bring the powder out of the inhaler and into your lungs. We thought this may be a barrier for him. He wasn't getting the same response, and so we switched him to nebulized treatments so that it would be easier to deliver the medication into the airways. With this, he again noticed an improvement. But we were only allowed to do that because his insurance was covering the change in alternative medications. We also started him on thrice weekly azithromycin, and since that time, he feels his exercise capacity is close to that after I first saw him, and he has not been in the hospital in the last 2 years because of his lung disease. So I would like to end with my recommendations of what we can do. If tobacco smoke is the most a significant risk factor for COPD, I think we have to have tougher anti-smoking laws. Not only will this help prevent the disease, this can also decrease the cost of patients who already have the disease. In communities who have enacted strict anti-smoking laws in public places, they've noticed a decrease in hospitalizations for heart attacks, heart failure, and COPD exacerbations.
Dr. Walker, I'll be glad to show you my scars. I passed the first anti-smoking bill that we have out of public places of getting that through. No, seriously, I agree with you on that one, but
Yes.
those are extremely hard. That was an extremely hard fight.
It is. I hope that after it starts, it gets a little easier because we realize that there are still bars in Atlanta. They didn't all close.
I know.
One of the other issues is improved coverage and access for smoking cessation. We have the quit line, but it is surprising how few people know about it, providers or patients. And so not even starting new services, but making existing services more accessible, even through knowledge.
Are you saying that all the insurance carriers are required to have smoking cessation programs?
That could be a possibility.
Oh, I thought you were saying. No, I thought you were saying that it was, and they weren't doing it.
No.
Okay.
It's not all insurances will cover. But even services that we have, like the Georgia Quit Line, oftentimes patients have never heard of this. They've been treated by other physicians and have not been referred to the Quit Line.
Okay.
An increased awareness of testing and therapies among all physicians, the public health education awareness that you were talking about earlier with Dr. O'Connor. this would actually coincide with the National Heart, Lung, and Blood Institute National Action Plan on COPD, trying to make patients more aware of symptoms and risk factors, and to seek advice from their physicians, as well as to increase testing and awareness of COPD among physicians. Also decreasing the burden of referrals for patients and providers, making it easier for patients to see a pulmonologist if they have been diagnosed with COPD, making it easier for them to receive spirometry for testing if that is in an area where their physician may not have that. Medical coverage for bronchodilators that not only covers them but also allows individualization of therapy. We're fine using a preferred drug, but if the preferred drug does not work like we expect, it certainly is reasonable to try a alternative medication at a similar cost. Support for more pulmonary rehabilitation programs and mandated coverage by insurance, I think, is reasonable to follow the federal government's decision for Medicare with this. And while outdoor air pollution is not associated with causing COPD, the data on that is very unclear. It's as incontrovertible that it is a major factor associated with causing exacerbations. When we see high levels of particulate matter in the air, when we see high levels of ozone, several days later we are going to see an increase in ER visits and hospitalizations for heart attacks, heart failure, and COPD. And so with that, I will end my talk and we'll be happy to answer any questions.
Okay. Do we have a representative from DCH here? Okay. All right. No. Okay. I think we need to look at our health plans and, about the medications and so forth. Can you get us, like on the preferred plan, we can't make the insurance companies do anything. It's one of our biggest problems. It's one of the problems we're having in opioids. Everybody likes to hit the doctors about prescriptions, and we are doing things on that. But some of the treatments that would be alternative treatments to giving somebody with pain, like physical therapy or like a massage, or some other kind of thing, the insurance company used to pay for them. They will no longer pay for them. So the person ends up with the only option for the pain is an opioid. Right. And, the insurance companies are bad about it. But we need to see, can you list a couple of medications and get it to me and about the preferred plans of what we do? And maybe it might be one area where the state can suggest, or as the plans go out for bid, that we really look at this if there's a cost effectiveness for the state.
Certainly.
Okay, thank you.
One comment on what you said. I will use an example again. The laws may be quite different, but a couple of years ago, the state of Vermont actually passed legislation that said insurance companies that are offering plans in the state cannot require prior authorizations, because the data showed that 95 to 98% of all medications that required a prior authorization were approved. So this was only adding unnecessary cost.
I got the whole MAG group would be want to join you there. Would make it easy in practice a whole lot better for everybody, providing care, not to have to go through that. We'll start with Dr. Price. We're going to be here a little longer than usual. I hope everybody didn't stick with us because we're running a little bit late. Dr. Price, go ahead.
Yes, thank you very much. I have a question about bronchodilator propellants.
Yes.
Probably, 10, 15 years ago when the federal standards disallowed very effective propellants. Do you think
Yes.
that's a factor in the efficacy of the current bronchodilators out there?
I don't believe that is as much in COPD because most of the medications have been dry powders rather than, so there is no propellant. The inhaler is actuated by puncturing a blister pack, shaving off a piece of a solid capsule, and then inhaling that powder. And so there is no propellant. In inhalers where we had CFCs that were since banned to HFAs, we actually don't have any evidence that those are less effective. When we look at HFA inhalers with radio-labeled particles, we actually find that there's excellent deposition of the drug in the small airways, which is where asthma and COPD start.
Dr. Felsing, we can keep our questions and answers succinct, and I'm going to have to provide lunch for the committee. And we'll be okay. I just wasn't, not today, but in the future, because it's interesting subjects. Go ahead.
Thank you, Madam Chair. I've got two questions for you. One, could you just highlight the percentage of smokers we have in the state, percentage of secondhand smokers, and also comment on, are there spots where smoking is a lot less, like Dr. O'Connor showed with diabetes and hypertension, and why do you think that is, and can we benefit from their knowledge, and or do they have best practices? That's going to be my first question. My second question is, and I've read a lot about the use of azithromycin as an anti-inflammatory, but the concern, of course, is there any data yet, and I haven't seen it, in a trickle-down effect where azithromycin suddenly in the communities where it's highly used for anti-inflammation is not going to be effective for pulmonary bacterial processes. Plus, year by year, state of Georgia is either 6th, 7th, or 8th in the nation for gonorrhea. We have higher rates of chlamydia, and all of a sudden we have a highly drug-resistant organism like gonorrhea, and we're running out of options. And with such high rates, are we going to suddenly lose azithromycin? And we always use dual therapy in gonorrhea. That's what the CDC is recommending to try to minimize the rapid resistance of our cephalosporins. Are we going to push that a little bit faster?
To answer your first question, I don't know if anyone in the audience has this. Unfortunately, I don't have recent data on the rate of smoking in Georgia. The national average is about 17% smoking rate among adults. Georgia is probably slightly above that, maybe around 18%.
And I'll add to that before you answer my second one, because I didn't ask. E-cigarettes are everywhere. So how is that also?
They are everywhere. We don't know yet. There's not enough data. There have been some large grants from the federal government in the past couple of years for centers to study what the health effects of the e-cigarettes are. I think one of the things to remember is if we look at the tobacco in a traditional cigarette, there are about 1,000 chemicals in there. We've identified at least 7,000 chemicals once you light it. So even though the e-cigarettes say we've only got these 3 things in them, we have to know that once we ignite them, there's going to be more. There's going to be different chemicals, and we don't know exactly what the effects are. And so I think breathing in any smoke is a problem, and should avoid that. I've been told that in 18 and older in Georgia, the latest data from the CDC, 21.2% of the population are smokers.
Okay.
And the question about
on
resistance, developing
azithromycin.
resistance.
I think the resistance with gonorrhea is probably a true concern. And again, we ought to be judicious in our use of the azithromycin in some of these patients, that it really should be the people that are coming to the hospital regularly to try and prevent that. As far as resistance in pulmonary or respiratory infections, we don't have any evidence that that's problematic. One of the concerns raised several years ago in the cystic fibrosis population, where azithromycin's been a cornerstone of therapy for many years, was that in vitro, it looks like azithromycin may impair the ability of white blood cells to fight atypical mycobacteria. However, when we look population-wise, patients on azithromycin are less likely to develop infections with NTM. And so I think that we don't have any clear data that this is a risk. Azithromycin is used frequently for respiratory infections, but probably inappropriately so. It's not great for what we use it for. We're giving it to kids for ear infections and sinus infections, and it's not a good drug for that, as you know.
Before I go to the next question from Dr. Graham, I would, since we're going out on the House website, this is live, we did manage to pass the expedited partner. Senate was a little unhappy with us over that. I did manage to add it to another bill, which means if somebody thinks they have gonorrhea or they got chlamydia and they go into the physician's office and they are diagnosed, the physician can now send home a prescription for the partner that apparently infected them, if that is the case, or whom they have infected. Was not something we could do before that. That law went into effect in July and hopefully will help fight our problem in the state. Dr. Graham, for the last question.
Yes, and it's more of a comment, Representative Cooper, but to follow up on your question regarding the state Medicaid plan, I serve on the Drug Utilization Review Board for the state, and so if you get that list of medications in terms of those that you think are effective that are not preferred, be happy to work with the DCH representative on that.
And this is what we're looking for. So if you'll
Excellent.
get it for Dr. Graham, we're hoping that we can do that. Thank you very much
Not a
for
problem.
coming.
Thank you for your time.
Dr. Foreman, and then I'll go to Dr. Bridges, and I really apologize for us running a whole lot later. Part of it's because we got to start, but then we'll work on, we don't want to shortchange anybody. And Dr. Foreman's with Morehouse School of Medicine, and if you want to introduce yourself more than that and tell us what you're working on.
Thanks.
Okay.
I'm Marilyn Foreman. I'm a pulmonary and critical care physician. I am a professor of medicine. I've lived in Atlanta since 1992. I came here to work for Morehouse School of Medicine. I've lived here all but 3 years when I left for a fellowship and then returned. I'm a native Alabamian. In terms of interesting things about me, in terms of work-life balance, I think I'm one of the more boring persons. I do more work than anything else. But I did want to say that the clinical people who are the loves of my life are respiratory therapists and critical care nurses. So it was a pleasure to hear from you this morning. It's also a pleasure to meet you, Madam Chairman.
Oh, thank
I've
you.
heard great things about you as well.
I care about patients. That's my first priority.
My
Thank you.
academic focus is chronic obstructive pulmonary disease, but Dr. Walker gave that great distillation of the burden of COPD amongst our patients. So I decided to pivot a little bit and just to talk about tobacco smoking, because those people who continue to smoke, those are the people who are at risk for COPD in the future. So I think they need targeted interventions, and we need to put focus on treating tobacco addiction and preventing smoking. So my objectives today are to tell you about temporal trends in smoking that affect COPD prevalence, to identify the groups who have higher rates of smoking, for whom COPD is the future risk, and to make recommendations for targeting smoking cessation and potential COPD prevention in these groups. My intention was to speak verbally. Oh, sorry. But I brought these slides, and hopefully I can use them for illustrative purposes.
Okay.
So COPD was primarily in men back in World War II because men smoked more. But smoking sort of peaked in men in the 1970s. But also during that time, I think you can remember there was targeted marketing, actually go back, to women. And I think you can remember that slogan, "You've come a long way, baby." So there was marketing to women that sort of supported their freedom and autonomy, and they were also marketed to say that you had this special cigarette that's slim for your slim fingers as opposed to the chubby fingers of other individuals. So once women started to smoke more, COPD now has become a relatively recent phenomenon for females. In the year 2000, women achieved a dubious gender parity when the death rates in women exceeded those for men. This is some data from Earl Ford when he was at the CDC, and he looked at adjusted mortality rates, adjusted percent mortality. So you can see from the top line that for men, that the change was negative. It was a 1.1% reduction. And he looked at data from 1968 to 2011. But for women, that adjusted percentage mortality was actually positive, and it stayed positive. Even though it was a low change, it stayed positive for some years to come. This is just a graphic representation of the same thing that I told you previously. If you look at 1959 to 65 for women, the rates for mortality rates were very low, but they were higher for men. But then over years, as women tended to smoke more, the mortality rates for women have increased. This is a classic paper from David Menino when he was at the CDC. He's currently at the University of Kentucky. And this just shows that the death rates for women tended to climb somewhat, especially since the year 2000. So even though the absolute death rate is higher in men, it was the absolute number of deaths in women exceeded the number of deaths in men. So the rate is a proportion. So this is just to remind me that there are different groups for whom smoking is not beneficial. It's really not beneficial for anyone, but there are some specific groups that have actually increased risk. If you remember the Healthy People 2012, the rate of adult smoking was targeted to be 12% or less, but we didn't achieve that in 2012. So the Healthy People 2020 target is also 12%. But there's some good news. The smoking prevalence has reduced. It has gone from almost 21% down to 15.1%, and that's a change from 2005 down to 2015.
That's nationwide?
That's nationwide, correct. That's nationwide. In terms of minorities, African Americans have the highest incidence and mortality rates for smoking-related lung cancer, and this is despite the fact that African Americans start to smoke at later ages, have less intense smoking, and also have less non-daily smoking. And despite that knowledge, tobacco cessation advice is not offered to African Americans as often as it should be, and it's lower than for other individuals or other groups. This was to remind me about smoking in youth and young adults. In the year 2005, high school seniors had an increase in their rate of smoking. In 2015, 9.3% of high school students were smoking, and 2.3% of middle schoolers were smoking. I found that to be phenomenal.
What was that number again?
2.3.
2.3% of
In
middle
middle
schoolers,
school.
6th through 8th grade?
Yeah. middle
Smoke.
schoolers. Yes. And that's American Lung Association
Okay.
information. So in young people who have attempted to stop smoking, say from the age of 16 to 24, 2/3 of those have expressed the desire to stop smoking in 6 months, but they don't get much assistance. So less than 20% of those get nicotine replacement therapy, and less than 5% of those use a quit line. So those things might now show up. So some of that increase in smoking that was seen in the high school students was thought to be due to rising cigarette prices, the decrease in state funding, increased smoking that's depicted in movies and advertisements. So this is about smoking in movies, and this is just to remind me that young people are exposed to a lot of smoking depictions. So the bottom, the dark blue, happens to be the G-rated movies, and the blue in the middle happens to be PG-rated movies, and then the lighter blue are the R-rated movies. But there is a study that was done in California. It's called the TUTD study, and that's for thumbs up, thumbs down, and that was done by Breathe California. And they looked at movies that were done in 2016, and they reported that in any given week, 41% of the movies that were the top 10 grossing movies, they had tobacco smoking depictions versus 45%. So that was a decline over a 5-year period, or 6-year period. But even though there was a decline, that decline stopped in the year 2010. So if you look at the youth-rated movies for 2016, the smoking depiction was 26%. Previously, it had been in 2010, 31%. Even though there was a decline, it stopped, though, after this time period. So there are other groups who have higher rates of smoking, and that's also the LGBT community, and they've got specific factors that influence them. Those might be cultural factors and psychosocial stressors. Those cultural factors are things like salience and identification with LGBT identity, and they also have these other stresses. They've experienced discrimination and violence, or they report them. They experience stigmatization. They also may have to conceal their sexual orientation, and they feel stress too from internalized homophobia. So this again is about the Healthy People 2020 goal of less than 12% rate, 12% smoking prevalence in adult smokers, and it shows the declines. In 2005, that rate was almost 21%, and now in 2015, that rate is 15.1%. So in 2005, that was 45.1 million smokers, and that's declined now to 36.5 million smokers who are active smokers. So there are also some disparities despite this gain, this reduction in smoking. In 2014, it was reported that there was a higher prevalence of tobacco smoking associated with type of insurance. So individuals who were on Medicaid had a smoking prevalence of 29.1%. The uninsured had 27.9%, and that was in comparison to people who had private insurance, and their rate was almost 13%. In 2015, there was a difference found that in people who reported serious psychological distress, their rate of higher smoking was 41%, and that was compared to 14% in the people who did not report serious psychological distress. There's an association between higher rates of smoking and occupations and educations and residents. So if you have an occupation that has more manual labor, but there's a higher rate of smoking. I found this study to be pretty interesting because people who are not high school graduates had a 26.5% rate of prevalence of smoking, and those who were graduates who had a GED had a prevalence of 26.4%, but the people with higher educational attainment had higher drinking rates. They had more alcohol consumption. I just thought that was funny.
Gonna get you one way or the other.
I guess so. So in terms of genders and ethnicities, there are certain groups who smoke more than others. So the highest rate for active smoking is in men who are American Indians or Alaska Natives, and that prevalence is 32.1%. If you look at white and black men, their rates are somewhat similar, 25% in African Americans and almost 22% in whites. The lowest rate is in Asians, Asian Americans, especially Asian American females. It's also a little bit lower in Hispanics in comparison to whites and blacks. This is just a map to show where COPD exists, and this is in comparison to where the prevalence of smoking by states is depicted. I think that was one of the previous questions. So most of the states where there is COPD, it's along the Ohio River Valley, and the state with the highest prevalence is Kentucky, and I believe it's like 9.7%. But for tobacco smoking, active tobacco smoking, it also follows that same distribution. So, in conclusion, for my brief remarks, cigarette smoking prevalences associate with socioeconomic status. That includes educational attainment, type of insurance, and residence, which I didn't show you data for, but there's a higher incidence of smoking in people who live in apartments. The cigarette smoking prevalence is higher in some racial and ethnic and gender groups, and I showed you information for whites, blacks, Native Americans, and also for the LGBT community. And you can see that there have been changes in smoking. As it waxes or wanes, the rate of COPD goes up or down, and the COPD mortality sort of parallels that. So that's why I'm concerned about the people who continue to smoke, because in 20 years, those are the people who will probably have higher rates of COPD. So it is expected that COPD will become a disorder of the socioeconomically disadvantaged in the future, and I think that's going to be a problem. You can find data that supports this in Canada. This is an oversimplification, but Benjamin Franklin said an ounce of prevention is worth a pound of cure, so we should try to stop smoking or to treat tobacco addiction. Now we live in the precision medicine era, so maybe we can have some precise and more targeted treatments for specific groups. So for the LGBT community, perhaps the counseling could give messages that address their cultural and psychosocial stressors, and that may impact their successful quitting. We should also advocate for policies that are less negative for the LGBT community and for, say, the minority community. So we should advocate for smoke-free environments, and I think you, Madam Chairman, said you had
As good as I could get it.
you had obtained successful legislation for that. And that's in order to try to counteract the tobacco promotion advertising. Also, we should screen adolescents for tobacco use and should also give them our treatment, because it's well known that, or it's estimated that every cigarette that you smoke will decrease your life by 11 minutes. I took some of these slides from a good friend of mine. He's Dr. Mario Castro, and he's at Washington University School of Medicine, so I wanted to attribute some of them to him. And I thank you for your attention.
Oh, Dr. Foreman, thank you for all your information and for waiting and hearing us out. And I don't want to pass us the opportunity to praise Morehouse. You are training physicians who have an emphasis in going out and being family practitioners.
And they stay in Georgia.
And stay in Georgia, and we're willing to go to our rural areas, many of them. And thank you for the school for taking students who couldn't get in other medical schools because their MCAT scores are a little bit lower, and helping them with the little extra help they need, and now they're knocking the tops off their scores in medical school. So for that, I think Morehouse, and for all the faculty there, I'm really, really impressed in what y'all are doing. So thank you. Any questions? I don't think I have any. I don't have my board lit up, but thank you for that information.
There was a question about azithromycin, and I think, and antibiotic resistance. I think that for pulmonologists, we're more concerned with the hearing impairment that you can get from long-term azithromycin. And I don't think there's data that shows that there are changes in resistance for the general population.
Right, because we're early on in that process, because there is data coming out that came out, of course, with the barrage of the azithromycin that was being poured out of ERs and urgent care centers for upper respiratory viral syndromes, and showing that in areas specifically where they're overusing that, there is resistance, and that's outlined beautifully by the ABIM under Choosing Wisely. But I'm always attuned to that when other groups are starting to use these antibiotics for other things, to just to keep that on a watch, and maybe a possible study for Morehouse or Emory to start look at this as it's used more and more across the state and across the country.
There was one more comment. I hope I won't delay things. I would hope that all insurance companies have all of the treatments available for everyone. I'm skewed because I work at Grady, so patients don't have much money. Right. But if nicotine replacement therapy is over the counter, it's not available by prescription, so patients can not obtain it sometimes. So it's very hard for me to get it for some of my patients. I do have them try to call that quit line. I try to have them call while they're sitting in the office, so I know that they call, but I don't always know what they do once they go home. So there are nicotine replacement therapies. There's a patch, lozenges, and lollipops, and then there are oral medications, at least 2 of them. So there are at least 7 medications that are effective. But it would be nice if all of those medications are available despite your insurance type.
Where they would be over the counter?
No.
Or that insurance would pay for them?
For Medicaid patients, it might be good if maybe if they pay some nominal fee, but I have so many patients that I can't get it for.
Okay.
Because they use that money for transportation or for something else, and they can't afford it.
And it's probably not something that pharmacy, I don't know. I wonder if the free pharmacy will have those medications.
Or if they have coupons or something like that, and patients might get a discount or something. But
I don't know.
But for my patients, for the patients at Grady, it is difficult to get nicotine replacement therapy because it's not covered under pharmaceutical plans,
Okay.
pharmacy plans.
Thank you.
Mhm.
Thank you very much. Okay, Dr. Bridges. Dr. Bridges, I guess I'll just say we've saved the best for last, but with no, speaking not ill of everybody else that's presented too, but
I'll try
to say
get that
thank
out
you
later.
very much for coming and for waiting with us.
Yeah, thank you for having me. My name is Tracy Bridges. I'm an allergist immunologist raised in South Georgia, came off the peanut farm, MCG, UAB in internal medicine, and then finished up in allergy and immunology at Vanderbilt.
Go turn it up.
Back on the farm down in South Georgia, so I bring a rural perspective, still interested in agricultural as well as medicine. So I want to talk to you today about asthma treatments and the problem of asthma, thank you, in Georgia. Basically, asthma treatments are largely based on inhaled therapies. A lot of patients don't think of inhaled therapies as medications. They think of medications as what they swallow. But these inhaled therapies are the basis of treating patients with asthma. And there's two broad kinds of asthma inhalers. There's the daily controller medications for long-term management, which are absolutely critical in the success of treating asthma. And there's the rescue quick relief inhalers. And if you look at them, they all look about the same. So there's a great deal of confusion for patients in treating with these medications. So many asthmatics do not understand the difference between the two, and many look alike, and patients tend to use what works acutely, which are the rescue medications. Now, this is from Georgia Asthma Coalition, a little bit hard to see, but working from left to right, you see the green, yellow, and kind of the darker yellow colors are orange. These are the asthma controller medications, and there's a variety of different inhalers that are available. You see there's a litany of them. Over in the red are the rescue inhalers, and they look very much the same. The key success in treating patients with asthma is to fix the hole in the roof. And I talk to my patients about this a great deal because there's such an emphasis on kind of just looking at what's inside the house rather than getting up on the roof and fixing it. And I hope this analogy will show through as I go through the slides. So painting over the ceiling certainly doesn't fix the problem, and that's what albuterol or rescue albuterol does, those medications in the red column. And that's one of the problems in asthma. We have so much overuse of the albuterol rescue medications with little education about sticking with the control of medications. Education is so important in this disease process. So what are the consequences of an unrepaired hole in the roof for asthmatics? Certainly missed school or work, unscheduled health care visits, which adds to the bottom lines for anybody who's paying those bills, ER visits, hospital admits, and also death. Now, the National Heart and Lung Institute has a well-designed plan for treatment of asthma, which is based on evidence-based medicine, and it is quite clear that the daily use of a control of medication that is an inhaled steroid and an inhaler reduces airway inflammation and prevents exacerbations of asthma. About any kind of endpoint that you want to see reduced for asthma, an inhaled steroid taken daily can do it. But the problem is, in the blue, getting patients to use a daily medication to avoid episodic exacerbations is hard to do. So what I tell my patients in my practice is, like high blood pressure, like diabetes, like cholesterol problems, you've got to take the medication daily to achieve the goals that we want to get, which is hard to do in a young population and an old population with asthma. So these are the NHLBI asthma guidelines, and basically there's a step guideline based on evidence-based medicine. And really, if you kind of look at step 2, step 3, step 4, step 5, it's heavily predicated on the use of inhaled corticosteroids in the form of inhalers taken daily to reduce inflammation and to reduce exacerbations, ER visits, and improve quality of life. So in this cartoon, I've just kind of replicated that stepwise guideline, just emphasizing the daily use of inhaled corticosteroids for treatment. So rather than before Irma or Harvey comes, just buying a gallon of white paint at Home Depot and painting over the ceiling with albuterol, we're actually getting on the roof, fixing the roof, and with the inhaled corticosteroids, we're actually taking care of the root cause of the problem. Now, how effective are inhaled corticosteroids in outcomes from asthma? Certainly in this old study, treatment with inhaled steroids reduced admissions to the hospital 80% during the first year of treatment, which is quite phenomenal. We know these medications work. The struggle is getting patient access to these medications and making sure they know how to take them. If you talk to patients just about asthma in general, you can reduce ER visits by about 25%. Now, this is switching over to show you where the problems in our state are with respect to asthma outcomes. And anybody who's heard me talk knows that I have a real passion about telling patients, telling listeners, telling anybody who wants to listen that where the problems are is in Metro Atlanta, within probably a 50 to 60 mile radius of where we sit right now, Augusta Public Health District, and also Albany, looking at ER visit rates for the decade from 2006 to 2015. Now, this is looking at, and the source of this data is OASIS, State Department of Public Health, accessed just recently. And this is looking at combined death, discharge, ER visit rate by public health district. You see that below the NAT line, below the Macon, Columbus, Augusta, you see worse outcomes for asthma as measured by death, discharge, and ER visit rate. And then you see that clustering of problems in the Atlanta metro area. So this is looking again from OASIS at emergency room visit rates. Number one is Fulton at 808, where the Georgia average is 557 for that decade. You see DeKalb, you see Jonesboro, you see Augusta, you see Albany, and you may not be able to read the percentages on the side, but these are 45, 43, 39, 32%, 26% higher than the state average. So these are the hot spots in the state as far as asthma is concerned. Now, I would like to think, being from Albany, that all of this problem can be solved in Albany, where I work and play. But really and truly, if you look at the total ER visits, which there were 542,806 ER visits from 2006 to 2015, 41% of them have been in metro Atlanta area. So if you're going to focus on reducing asthma in this state, as far as measured by ER visits, you really need to focus on Fulton, DeKalb, East Metro, Cobb, and Douglas, because that's where almost half of these ER visits have occurred. I will remind you that Morehouse, Emory University, schools of medicine are here in the metro Atlanta area. I showed you Augusta was a problem. That's where the Medical College of Georgia. So this problem is not remedied by the presence of a medical school in that particular region or locality, right?
Are more physicians and healthcare providers available, because we have a concentration of both those areas.
Right, and highly, so that's not really, I don't think, the answer to this problem. The question that I'm continuously asked is, are these ER visit rates getting better? We know that education has been going forward, the guidelines have been published, but if you look here at this graph, you can see that rate for all ages ER visits is really not changed in the decade from 06 to 15. That really the rate for all ages has not increased or decreased rather, but you can see a distinct rise in the 0 to 17 year Medicaid population. More use of the emergency room, more utilization, particularly in the last half of this decade. Now, what percentage of these ER visits, around 500,000 ER visits over a decade, are non-Medicaid, and what percentage are Medicaid? About 40% are Medicaid. And what is very interesting is that we've got a captive audience who tends to utilize the ER visit, and by captive audience, I mean these are the aged individuals that are present in our school system. So I think that's a key point here. About 47% of these ER visits are between the ages of 0 to 17. So where we were talking about COPD as being a disease of the elderly, asthma is a disease of all ages, but it affects young people a great deal, particularly in that 0 to 17 year age group. Now, here's some math. I'm kind of a math person. This data is from the Department of Public Health and OASIS. So what I've done here is basically taken the ER median charges for ER visits from 2012, which is the most recent data, which is around $1,500 for adults and around $1,200 for children. So over a decade, the 0 to 17-year group multiplied times the number is around 300 million, and the greater than 17-year-old is around 430 million. So that comes out to around 730 million ER charges that have been charged in this state from 2006 to 2015. Looking at discharges, there's been about 100,000 discharges over the decade from 06 to 15, and about 30% of those were Medicaid discharges. And doing the math on that, where the most recent admission costs around $7,800, you can see that these admissions have cost about the same amount of money as all those ER visits have, which is around $780 million, and about $223 million of that is directly attributable to Medicaid. So we're looking at about $1.5 billion that have been spent in a decade from 05 to 16, 06 to 15, for ER visits and hospitalizations in this state, which is an enormous amount of money, obviously. What if we reduced by 10% ER visits and hospitalizations? That means that over a decade, we could save around $73 million in ER visit charges and could save around $78 million in hospital charges. And I think that those numbers, that percentage reduction is doable. I think it is. And I think you've got to be smart about how you do this because, you know, I think the guy who used to rob all the banks, they asked him why do they rob the banks, and they said, well, that's where the money is, you know. But if you target Metro Atlanta, Augusta Public Health District, Albany Public Health District, these are where the ER visit stats are the highest. And I think that the population that you could really focus on, because again, it's a captive population, they're in school, so you could kind of intervene through the schools to do a school-based intervention, is in the 0 to 17-year group, because almost 50% of those ER visits and 60% of those Medicaid asthma admits are coming out of this 0 to 17-year age group. So what intervention would you come up with to recommend to you to support or to endorse? I think there's a lack, continued lack of provider education on asthma. Evidence-based guidelines, as I showed you in the front of this talk about the Nhlbi and the preeminence of use of the inhaled corticosteroids to treat these patients with asthma. I think there's opportunities to partner with pharmacies, certainly to help with asthma care, optimizing AMR, which is asthma medication ratios. It has been clearly shown that if you've got an asthma medication ratio of greater than 0.5, it predicts future ER visit and possibly hospitalization. And I think it's absolutely important to have community-based asthma interventions, whether that's a school intervention, a home intervention, because what we're doing now, it quite literally ain't working, because you see that our asthma ER visit rates really have not changed that much in the last 10 years. What about provider asthma education? I think there's a lot that the Department of Public Health can do. I would suggest that the Georgia Department of Public Health sponsor at state meetings, state association meetings, internal medicine, pediatrics, family practice, nurse practitioners, physician assistants, that they sponsor an evidence-based NIH guideline review. It would be a non-biased review from a national expert in the care of asthma. I also would suggest, like someone else mentioned, speakers, I think it was Dr. O'Connor, who talked about lunches and learns, is what I call them, that if you were to really have a map and really go into these high utilization areas like Metro Atlanta, also into the Augusta and Albany public health districts, and make a focused effort on talking to providers about education of the guidelines and the need to use inhaled corticosteroids on a regular basis. Now, let's talk about pharmacy collaboration. When I write a prescription and I see the patient 6 months later, I have no idea whether they have gotten their control of medication refilled. And I think it's an important opportunity to collaborate with the pharmacy and use this AMR ratio I'm talking about, the asthma medication ratio. And basically what that is a ratio of field controller medications, like I showed you on my poster in the green yellow columns, to the total asthma medications during a year. So in the numerator, there's going to be those rescue inhalers, and so that's what's going to skilt that ratio to less than 0.5 or greater than 0.5. So if you can get the AMR less than 0.5, that's going to be associated with a higher utilization of the ER. If you can get it greater than 0.5, in other words, more control of medications used, not just relying on the rescue inhalers, okay? And I think that pharmacies, providers, and CMOs should be required to provide an AMR and to intervene in some way to get that ratio higher, reflecting increased control use. Now, what I'm particularly interested in is community-based interventions. I've already mentioned that the places in Georgia where we have the most problem with asthma is Metro Atlanta, where we have two very good medical schools, Augusta, which has the Medical College of Georgia. We've got greatly trained physicians and providers in those areas. But other states are doing other things that I think are very innovative. Some states are going in and doing home health assessments and home health visits, and there's some good data out there that shows that if you go in on the home turf of a patient with asthma and meet them where they live and go over education issues with asthma and talk about control of medications, you can really make a huge difference. I'm particularly fond of this model for the state of Georgia, which is the Breathmobile model, and I've been thinking about it for a number of years. It has been used in a number of different states. These are just a list of publications in the medical literature that talk about the Breathmobile. But basically what this is a mobile asthma clinic that provides on-site care to asthmatics. And there's units in Los Angeles, Baltimore, Mobile, Alabama. There's also, I think, 2 different units in California. And there's a number of published trials which support its use. This is an example of one. This basically was published in 2010, which showed a dramatic improvement in cost savings per study participant down at the bottom of around $3,500. This showed that ER visits went from a mean of 4.86 and after 1 year in the program went down to 0.69. Hospitalizations decreased from 0.63 to 0.11. Obviously, these numbers are highly statistically significant, and the cost savings per patient year are shown there in the number of patients treated. So you can see that the math gets pretty great pretty quick when you multiply those numbers out. So this also just shows you that the ER visit cost dropped from around $3,100 to $439, and so on and so on. Now this is data looking at the AMR ratio that I've been talking about, that in a Breathmobile model, if you involve a patient in that particular model, you can have a 52% reduction in average numbers of ED visits post-year for the cohort versus 13% for usual care. So a 52% reduction is quite high. So why do I like the Breathmobile approach for the state of Georgia, targeting Metro Atlanta, this 50-mile radius, and Albany Public Health District and Augusta? There's well-established protocols and SOPs in many states and cities. The data supports its effectiveness. It's not like you're reinventing the wheel. No pun intended. You really have models and data out there that show this model is effective. It can target the 0 to 17-year age group on school campuses, which is a captive audience. A lot of problems that we have in South Georgia, we've talked about rural health here, is patients that live in Bainbridge have to drive 90 miles to see me in Albany. But if you could focus in on these areas and get a breathmobile down 90 miles from an asthma specialist with an asthma specialist on board, then you could see that you could really bring the medicine to the patient rather than the patient having to find a way to get to you. I like the visibility of a breathmobile because it may not be very clear on the picture I showed, but you're kind of bringing awareness to the community with the breathmobile, because everybody's wondering, what does the breathmobile do, or what is this that's in our community? And obviously it's raising awareness of asthma. And so it can be used in urban, suburban, and rural areas. And what I would suggest, if there was a way to use a breathmobile in the metro Atlanta area and really carpet this area with this mobile asthma clinic, and then have another breathmobile that would service the more rural communities, particularly Augusta Public Health District and also Albany Health District. I think it would be a great opportunity. So summary, daily control of therapies with inhaled corticosteroids is key to improving asthma control, reducing ER visits, admits, and also death. Treating asthma is not real difficult. The medications work. The difficulty is in getting medications to the patient and getting them to take it regularly, because that's always a problem in a chronic disease. Education is such a key part of this, because patients identify their inhalers not by the name, but what they look like. That's why I have this poster that I showed you early in my office. I can't practice without it, because I ask the patient what they're on, and then they point to this and this and this. Even highly educated patients cannot tell you the name, but they can identify them by the way that they look. And that gives you opportunity to say, this is controller that you use daily, and then this is rescue. And as my eyes get worse as I get older, I can't hardly read the small writing on the inhalers anyway. So I'm starting to have a little bit of sympathy. Education on part of providers and patient is key to achieving all the above. Access is key to trained asthma healthcare providers to medications from pharmacy. I see patients all the time referred in from primary care physicians who should have been on daily control of asthma medications years ago, and they just haven't pulled the trigger. Maybe it's education, maybe it's confidence, maybe it's experience. They're kind of scared to put the patient on a daily medication. But what do you have to lose based on these very sad statistics that I've been sharing? Monitoring is key, and having insurance companies cover physicians for monitoring patients with asthma, PFTs, fractional expired nitric oxide, impulse oscillometry, measuring the AMR ratios, and these may be helpful in predicting an exacerbation and allowing you certainly to intervene. I wanted to show you a quick video on the breathmobile, but if you feel like don't have enough time, we'll forego that.
Can we do it?
It's about 3 minutes.
We okay? Go ahead.
The Breathmobile is a mobile asthma and allergy clinic that travels to public schools, elementary, middle, and high schools to deliver free asthma and allergy treatment as well as education. We go to about 25 public schools in Long Beach, as well as a few schools in the South LA area.
Access to asthma care in certain communities is not that easy. The most common cause of school absenteeism, 10 years ago and even today, is asthma. Perhaps by implementing these simple clinical evaluations at the schools, you could keep the kids in the schools and outside of the emergency room.
I first heard about the Breathmobile through my son's nurse at his elementary school. At the time, my oldest son, who's 15 now, was 10. He was experiencing some really bad asthma problems.
With the walking, it would be a hard time for me to take a breath because I'd be coughing and wheezing.
In 2007, I got laid off from my job, so I couldn't pay for $500 worth of medicine and put food on my table.
We provide, pulmonary function tests, we provide allergy testing, counseling, advice, all of these services absolutely free of cost.
The doctor performs a thorough medical history, a physical exam, and then depending on their symptoms, the doctor may recommend some medication, and then they're given an appointment for approximately 6 to 8 weeks later. So they come back and see us regularly for treatment of their asthma and allergies.
The Breathmobile, it affected our lives because it brought some things to surface that I took for granted, and they were really able to help me better look into my children.
As a result of being placed on the right medication, they were able to sleep through the night without waking up coughing or without me having to take them to the emergency room.
It's actually given me a better quality of life, and it's helped me to conquer challenges that I couldn't even do before.
One of the most important missions of UCLA Health is to expand their involvement in the community. For UCLA Health to expand into the community and address almost everyday problems and building that trust in the population at large is very important.
The staff on the Breathmobile has been like family to me. They've seen my boys grow up. It's just amazing. Every time we come here, I feel welcomed and overwhelmed with everything that they've done for my family.
I'm very grateful to the school community, very grateful for the school districts, for how they have embraced us. And I'm grateful for the UCLA health system that has provided us, again, the framework that allows us to work this way.
Okay, thank you so much for your attention, and I'll be happy to answer any questions that I might be able to answer.
We do. The board is lighting up.
Oh, goodness.
Told you, even at this hour, we're interested. Let's do it. Okay? Dr. Price first. Dr. Price, you're first.
Thank you very much. Regarding the ER visits, of those visits, how many are repeat visits as opposed to initial?
I thought about that about 5 o'clock this morning, that somebody would ask this question. And so I looked at the asthma data that was published in 2015, I think reflected in 2012 by the state of Georgia. And about 18 to 20% of these ER visits are repeat visits. So there's at least one, obviously, if you go to the emergency room, but about 18 to 20% are repeat visits. And on average, when I did the math this morning, those repeaters average about 3 visits.
Per year? Or?
Yes.
Or in that time frame?
In that time frame. So there's a population of severe asthmatics that's probably included, and that's maybe 10 to 20% of that asthma population that's difficult to treat, and they need more attention. And that's where these newer medications, the biological treatments that are coming out, are making such a big difference in the treatment of those patients.
And then my follow-up question, the mobile unit, it repeatedly said no cost. What does that mean?
That I'm not sure about, unless the only thing I could think, if you noticed at the first, that David Geffen's name was there, and UCLA was there, unless it's through a grant, through some type of philanthropic organization that's actually supporting that.
So how would you propose we manage that if we had something like that? Or how would it be paid for?
I've thought about that. I think that anything like that needs to be owned by the Department of Public Health. I think that it needs to be controlled by the Department of Public Health. Where the funding would come from, I don't know. But I thought that if there were interest by the committee, that obviously we could reach out to our friends in California and ask those questions. I'm sure someone has the economic answers that you ask.
Thank you.
Well, along that line, I was fixing to ask the lobbyist for Children's Healthcare of Atlanta. Sounds like to me, Jason, you need to go back and see if a Breathmobile type thing could work with the sponsorship, especially in this metro area of Children's Healthcare of Atlanta, and work something out with the schools. And don't you, I mean, I used to raise money for Children's Healthcare, and one of the groups that helped raise money, the volunteers, don't they have a big foundation that we might sponsor the cost of a breathmobile, and certainly the physicians to the one to staff it and to go out and all, would keep people out of your children out of your emergency rooms. Okay, would you please run that up the ladder?
Wow, that was easy.
Well, it isn't done yet, but I mean, I'm willing to come and talk to anybody I need to talk to at Children's, and I do know that they have a pretty good foundation, and if you're saying this will keep children and make them healthier,
Right.
let's go to that source. They're the ones that have to treat them in the emergency room.
One comment is that I think there's such a unique opportunity in the metro Atlanta area because the geography is compressed, where blanketing with a breathmobile would be certainly easier. Now, I want one in Albany, don't get me wrong, okay? I want to be riding over there in the captain's seat. But I think that in the metro Atlanta area where you have this 40% of the ER visits.
Are you listening, Jason? 40% of the ER visits are in Atlanta?
In this metro Atlanta area, that you really could use something that's been done elsewhere. And I think the savings are there to pay for it to pay for itself.
Jason, stand up, and could you, when we finish quickly, tell him where they would need to call or who you call to find out information on the one in California?
Okay, yeah. Okay, I will.
Okay. Dr. Graham.
A couple questions. My thoughts were actually a little different about the breathmobile because it looks like the parents are required to be present for the visit, at least in the video. And at least in the areas you mentioned where we have high populations of children going to the ER, we also have a high population of providers. And so I'd assume that if the parents have to be present, it's not lack of access to care that's the issue.
Right.
There may be other issues involved, whereas in the more rural areas of our state, lack of access is actually more of an issue, where it may be helpful to have the breathmobile go to those areas where they really don't have the providers, but look at what other factors are driving the lack of parents taking kids in for treatment in the metro area. Yeah. My other thought is really looking at, kids don't take their own medications, and so we really require parental input for compliance. And we often try to avoid administering medications in school, but really looking at a program of having the daily corticosteroids administered at school, where you have 5 days out of 7 compliance versus none, being an education method that would improve compliance for those school-age kids rather than relying on the parents, so that at least for a great portion of the school year, you have increased compliance.
Great comments. I know in South Georgia, there's been some initiatives to get in-school clinics, health clinics, and I'm not sure if parental consent or presence has to be.
It
It
does,
does,
but a
okay.
lot of them, I think, almost have a blanket. It would have to be added on. You could cheat I think they can, because we just did it for the dental hygienist, and they can, if they want to clean teeth, the parents want them to let them clean their teeth. They can give permission if they have a mobile unit or if they.
But does the parent have to be physically present?
No.
Okay.
But they have to have the permission.
Permission to do it.
The school sets up.
I think that's the
kind
way
of
it is
thing they
in the Albany school health clinics, that the patient can be treated, but the parent doesn't have to be present, but they give permission.
Right. The problem is we require the parents for compliance.
Yes, that's
you're
exactly 100% right on that. But I like the idea of a school, a nurse, health official in the school to administer the asthma medication. That's a great idea. One reason I like the breathmobile is because it's already been done somewhere else in numerous big cities. So you're not kind of trying to come up with something. You're just plugging in something that has been used elsewhere in a metro area like Metro Atlanta. That's where the UCLA experience, I believe, has come from.
Dr. Felsey?
Thank you, Dr. Bridges. That was a wonderful presentation, just like our other presenters, and I appreciate that. And I'm very excited to hear more about the breathmobile. I don't think there's a silver bullet to this issue, and I think telemedicine, as we expand upon that. I don't think lunch and learns are, I think they're the thing of the past, and I think what Dr. O'Connor had mentioned in the Project Echo, I had mentioned we've got to start to build communities instead of having these points where we go in and we touch a community one time and we don't leave any type of footprint. So I think these type of things will leave footprints because not only you're physically present, and you can be virtually present also, and I think those are very important. I just wanted to say those comments. But the other side of this is all these conversations are client-driven, and that's important, but has anybody done any surveys about, and I'm going to point this out, I'm not talking about providers specifically, healthcare staff that are smokers across the state, because what I'm getting from my clients is they come in and they say, you know, it's a double standard. You're in here telling me not to smoke, but yet when I got checked in, I could smell smoke. When someone took my blood, I could smell smoke. And it really sends a mixed message. And I'll give you a personal story. When I did Indian Health Services years ago, I was 85 pounds heavier, and I was talking to my client about weight loss, and the client stopped and said, why should I take advice from a fat doctor? Now, when after the slap of reality hit me, I had to think quickly, and I said, you know what? You're going to come back in 3 months, and you're going to be 5 pounds lighter, and I'm going to be 5 pounds lighter, and we're going to do this together. And I lost 85 pounds, and they lost about 65 pounds, and we were much, much healthier. But my question is not only educating these providers on asthma and COPD and all these other diseases, but they themselves, the staff themselves, are educating that they're sending this mixed message to our clients.
I agree. We've got several of our staff who smoke, and it's a minority, but we really wish that they didn't, obviously, for their health and also our reputation.
That's right. Representative Bennett, you get the last word. Last question.
The last word, last question, last comment.
Well,
I
not
get
the last
excited.
word. Not the last word. Last question.
Last question. I get excited about community-based opportunities such as this. I'm reminded when I was growing up, we had a bookmobile that would come into our community. So this reminds me very much of that, and was heavily utilized and accessed. And so I want to thank Madam Chairman, for already putting some information out as to how we could get that done.
Yeah, we have a representative here from the Medical College of Georgia, too, down in Augusta.
And what I'm seeing also, Madam Chairman, is an increase in trucks that are being sponsored by CMOs and other health cares that are coming to the community, so I know it's possible. My question, when I saw the kids, when I saw the truck breathmobile utilized at school, kids tend to gravitate to cool things, and so my question to you was there any data or research to indicate the percentage of kids in a particular school who may have asthma versus those who may have utilized the breathmobile? Are you getting, are the kids utilizing it in comparison to the total number of population who have the disease?
I don't know the answer to that. Some of that answer to your question may be answered in those studies that I showed. In some of these studies, the N number studied is low. In some of the data from UCLA, I've seen some numbers in the 1,500 range that they have reported on, but I feel like that the service has been utilized in a greater population than that. But as far as how acceptable it is to the children, or what is the cool factor, or what is that, I don't know that I've ever seen that.
Yes, sure.
Cool factor was just a comment. I was just more concerned with total number of kids in a particular school or district or community with the disease versus the amount of access. So do we have an indication of how readily how utilized it's been?
Oh, I see. I don't have an answer for you on that. I just know that in our public schools in Georgia, it's been well publicized that there's a high rate of asthma in schools. And Francesca, you may be able to help me with this, 15% perhaps, something on that, 15 to 20%. So it's a ripe population for an intervention. They've got the ER visits, they've got the hospitalization outcomes. There's a lot of asthma in school-aged children, so you would hope that a school-based intervention like breathmobile or a school-based clinic would really make a big difference in asthma outcomes, not only missed days from school, which also means that the parent can also go to work as well, increased quality of life, decreased utilization of ER, hospital, and even decreased death.
Well, and thank you. I mean, I do know that the lobbyist for the school nurses, I think probably still lobbies for the school nurses well. I have spoken to that group. Not everybody attends, but I think that's one way that perhaps I could ask the next time they have a convention to talk to the school nurses about it and, you know, be aware of what a difference this makes. Might be one way of reaching it. One of the problems we have is that in our system, the legislature has no way at all of getting information out, even about the bills we pass. It's left up to the individual groups like MAG or to the Sheriff's Department or whoever to get information in the bills we pass out. It's one of the problems I have, but there are small things that we can do by reaching out to the groups that are involved and asking them to, like the family practitioners and so forth, to notify their members and the nurses and PAs and all, and something I think is very worthwhile. And Dr. Price, you came in late. You want the last question, burning desire, before we go? Because I was No. I had said I took the last question for Representative Bennett.
Well, I just had another clarification, if you don't mind, which, going back to the repeat ER visits, because if 80 to 85% of people have one ER visit and they go off and do well, and what is the difference in that population? Is it severity of disease or is it noncompliance of having ready medications?
It may be both. I've had some referrals to me from a very severe asthmatic with a repeat offender to the emergency room, and he had, all through that process, had even seen other asthma specialists, but no one had really emphasized the daily use of the control of medication. And when we talked about that, the light went off in my head, the light went off in his head, and as far as I know, he has been well controlled since then. So there may be some compliance issues, there may be some education issues, there may be some phenotypes of asthma that do not respond to inhaled corticosteroids, and clearly there are some patients who don't, and that's where these newer targeted biological medications targeting cytokines and interleukins are really playing out to show a real improvement in those particular patients. Now that's a particular subset of the population, but it may be included in the repeat offenders, returners to the emergency room.
And then, of course, the issue of continuing medications when you're feeling well.
Oh, absolutely. That's a battle we all battle.
Or when you're a child and you don't want to stand out in the crowd because you have to take a daily medication, and that's especially true with childhood diabetics that have to take it several times a day at school and carry the medicine with them. Thank you very much for coming, for all our presenters, to the audience who stuck it out. Thank you too, and especially to the committee members. We probably will start at 10 the next time, try not to go so long, and I really do appreciate it. I think out of this day, realize how serious these diseases are. They're killing Georgians if we don't control them. They're overpopulating our emergency rooms, and it's only problems that are going to grow worse. But there are no simple answers. It sounds like we are really going to have to build coalitions in all our communities to try to attack this to make any kind of a significant difference. Thank you very much, and I'll see you in a couple of weeks. Thank you. Next meeting is October the 5th.